Welcome to my presentation on blood flow restriction, age of hypoxia in diverse clinical settings, special coronavirus edition. These are some of the objectives I'm going to touch on today. Feel free to look at them at your leisure. This is the in-class activity that I had prepared. It's a basic true-false quiz that'll give you an idea of your blood flow restriction knowledge. And I'll be touching on these points during the presentation here, so I'm just going to skim past it. This is the answers to the aforementioned quiz, and the honor system is in play. Okay, so basic overview here. Our BFR story starts in 1966 with Dr. Sato. He noticed a muscle pump after kneeling during a Buddhist festival. Apparently these festivals can last for hours. His leg finally gave out and he was rubbing his calf and noticed that it felt the same way after he worked it in the gym. So that was the epiphany that kind of spurned a lifelong pursuit of bringing BFR to the general population. BFR involves the use of cuffs or wraps placed around the proximal limb, typically during exercise, but there are times when you can use it without exercise, and we'll touch on at least one of those. The aim is to safely restrict venous blood flow from working muscle while allowing arterial blood flow. So the safety issue in this is allowing arterial blood flow. To completely occlude arterial blood flow is contraindicated. Reduced oxygen to muscle tissue leads to fatigue of type 1 fibers and an increase in type 2 fiber recruitment. So basically you're creating a hypoxic environment that will fatigue out the oxidative type 1 fibers and preferentially recruit the type 2 fibers. So BFR tricks the muscle tissue into strength and hypertrophy without high mechanical loads. The mechanical loads we're talking about is based on the ACSM recommendation of 70% of a 1 rep max to reach hypertrophy gains. BFR is awesome because it can bring that down to 20 to 30% of a 1 rep max and open up the population wide for strength gains and hypertrophy. So BFR is applied during voluntary resistance exercise, aerobic exercise, or passively without exercise. BFR has been shown to slow atrophy during prolonged bed rest disuse or immobilization, and we'll look at a study a little bit later based on that principle, and they studied coma patients, so pretty interesting. Lighter weights and lighter intensity decreases the damage to the muscle and minimizes recovery time. So if you think about our basic high intensity training, you're creating a lot of micro trauma to the tissue, and then the metabolic activity after the exercise will go back and heal the micro trauma, and that's what increases muscle size and hypertrophy, right? So with BFR, you still get the same beneficial metabolites post-workout, but you get reduced damage in the muscle tissue. The principles of specificity, progression, and overload are needed to elicit adaptations. So the same things that you consider with high-intensity training, you still want to consider with BFR. It's just going to be at like lower loads. So further studies are needed to fully understand how BFR works. There's a ton of studies out there. If you're interested in this topic, by the end of this, you will have no limitation on the amount of material you can read. Okay, upstream, downstream, metabolic magic. Two primary causes for muscle hypertrophy that we're going to look at. The first one is muscle tension. Safely reducing venous flow slows metabolites and swell cells, triggering adaptive responses in the body. This swelling promotes an increase in protein synthesis and a decrease in proteolysis, which is basically a breakdown of proteins in a variety of different cell types. Swelling also causes capillaries to lengthen and expand, improving circulation and vascular elasticity due to nitric oxide. The way I think about that is, so if you're not using some capillary beds, just like anything else, it would tend to atrophy. So when you put that cuff on, it's going to increase swelling to the extremity, and it's going to force blood into all of your capillary beds and promote healing in that regard. Next thing is anabolic hormone levels increase and activate myogenic stem cells. So those myogenic stem cells are part of the metabolic response to healing of microtraumas that happen in the muscle tissue. Last one here, gradient-induced reactive hyperemia after removal of the cuff induces intracellular swelling and stretches the cytoskeleton structures that may promote tissue growth. The way I look at this is just so you've got a condensed muscle fiber, and basically that swelling is going to spread everything out and allow that those beneficial metabolites to get in between those spaces and increase healing and growth. The second part of hypertrophy that we're looking at is metabolic stress. So lactic acid, that's that burn that we're all familiar with during exercise. So lactic acid builds up with that cuff when it's in place, and when we take the cuff off, all that buildup of lactic acid then gets distributed systemically, signaling the pituitary gland to secrete growth hormone, which activates the body's metabolism. The other cool thing about lactic acid is the upstream effects that it can have. So lactic acid can cross the blood-brain barrier, and when it does that, it increases brain-derived neurotrophic factor, also known as BDNF, a hormone that increases neuroplasticity and cognitive performance. So there you go. Blood flow restriction can make you smarter. Okay, the next thing is nitric oxide. So we get an increase in that, and that nitric oxide allows blood vessels to constrict and relax. It also regulates the inflammatory cells in the blood vessel walls. So think of like your mast cells and that type of thing. It'll regulate. The next thing is the low oxygen stress causes the release of hypoxia-inducible factor 1 alpha, also known as HIF1 alpha, which increases vascularization in response to low oxygen. That then increases the hormone vascular endothelial growth factor, also known as VEGF, which increases signals to produce more blood vessels. So the studies that I was reading kind of refer to VEGF as like fertilizer for your capillary beds. So now we've got two factors here. We've got the increased pressure in the capillary beds that's helping to keep them viable, and then we've got an increase in VEGF, which is basically fertilizer to grow more capillary beds, which is a good thing. Next thing is myostatin is downregulated. Myostatin inhibits myogenesis, so muscle cell growth and differentiation. So an example of what happens when you knock myostatin out altogether is this bowl to the right here. So you get some pretty significant muscle gains there, which can be beneficial to a large range of patients and clients. Next thing is restriction of venous return causes reduced stroke volume and simultaneous increase in heart rate to maintain cardiac output. So basically we're reducing venous return by the cuff being placed on an extremity, and one of the speakers at CSM kind of described it as with heart failure, you've got a heart that isn't contracting efficiently, and so when you reduce the volume, that's going to play on the length-tension relationship, and so less volume is going to allow it to be in a more powerful position, and it can actually start contracting more efficiently. There's studies underway right now looking more into this, so I'm sure we'll see more of it in the future. So these are some current contraindications. Most of them are kind of common sense stuff that you would see not only with blood flow restriction, but any kind of resistance training. Always refer to this and use your common sense with contraindications. Some of the precautions that we're looking at here, you wouldn't want to apply these bands to both the upper extremity and lower extremities at the same time. If you did do that, you'd probably see your patient pass out on you, and when they woke up, they wouldn't be very happy. We're always going to be using relative pressure, not absolute pressure. So absolute pressure is full occlusion, so we're going to be basing our treatments off from like 20 to 30% to start with and working our way up. LOP is limb occlusion pressure. This is going to change daily based on hydration and several other factors. So every time your patient comes in, you're going to want to check to see what their limb occlusion pressure is and then base it off a percentage of that. So numbness is contraindicated. Check your pressures regularly to avoid that. You want to educate your patient as well with BFR. Some of your older patients that might not have worked out during their life, should probably be educated on DOMS, delayed onset muscle soreness, and you want to start them off slowly and build up to a higher percentage. That would be more effective. The other thing is distal application of the cuff is contraindicated. An example of that would be the lower extremity. So if I place the band on, let's say, my calf, I'm probably going to have damage to the common peroneal nerve. And so your patient could walk out of the clinic having drop foot and not be very happy with that outcome as well. The last little item here is a study that looked at side effects of BFR. And as you can see, they're very low. BFR is a safe treatment, but yeah, you still want to use that common sense when looking at patients that would benefit from it. Yeah, and then individualizing your treatment is going to be a huge part of BFR. You just don't want to take one protocol and run with it. Application of bands, this is going to be more common sense issues here. Wider bands cause less pain. Think of surface area, you're spreading the occlusion out over a larger surface area, which is going to be more comfortable for the patient. Tapered bands that follow the contours of the extremity are going to be more efficient at occluding. Potential bruising and shearing, especially in elderly patients that might have more fragile skin. So maybe think about putting something underneath the band to attenuate that. I know anecdotally, when I got to try this out at CSM, I ended up with some bruising on my biceps. So that definitely can't happen. Watching skin color is important. So pink, red, good, white, blue is bad, right? Extremity swelling happens during the exercise. So some of the higher end bands, you don't really have to worry about that. But one general rule is if you can fit one finger underneath, that's good, but you shouldn't be able to fit two. Next thing is to avoid hypoxic damage, you want to keep your treatments to under 15 minutes for the upper extremities and under 20 minutes for the lower extremities. If you're not sure of pressures, you can always do some blanching for the upper extremity in the thenar area. The lower extremity blanching can be done on the distal quads. Typical training and tips. Finding a 1 rep max is an important part of BFR. As far as adaptations go, you want to retest this weekly. You're going to see patients increase their strength more rapidly than your typical resistive training. So always scaling up and keeping them challenged is a big part of seeing benefits increase. So some general guidelines, most of the studies that I looked at had lower extremity occlusion pressure about 80% and upper extremity about 40%. Most of the protocols that I saw, the first reps were 30 for the first set, and that again is going to fatigue out the type 1 muscle fibers, the oxidative slow twitch muscles, and the remaining 3 sets really target the type 2 muscle fibers, and that's going to be 3 sets of 15 with 30-second rests in between is pretty common. And again, we want to keep the occlusion on during those 30-second rest breaks so that the metabolites can build up. Occlusion is maintained between sets to allow, so we just got done talking about that. And we talked about easing into training, so we don't want to start off at the 40% for upper extremity and 80% for lower extremity, especially with patients that have never experienced this before. You want to start low and ease them into it. Muscle failure by the final set is a good indication of proper intensity, so that's kind of the gold standard that we're looking for. We want to see them hit that muscle failure. Training sessions can be anywhere from 2 to 3 times a week, and you can progress upwards, and that's going to vary depending on the patient population that you're seeing. Okay, so for outpatient settings, following orthopedic surgery, when restoring muscle mass and strength, it becomes crucial for positive outcomes. So BFR can be huge for that. It can be crucial for prehab, rehab injuries, including strains, sprains, osteoarthritis, post-operative patients such as total knees, ACLs, rotator cuff repair. Basically, any non-weight bearing patient could really benefit from this BFR training. Patients that need early strength gains to improve function while minimizing the mechanical stress to muscles and joints. So we're going to see reduced pain following surgery. They actually use this for ischemic preconditioning. I'm not going to get too far into that, but so basically what they found is that if they precondition a limb with hypoxia before the surgery, they get better outcomes and reduce pain following the surgery. Also, reduced workout time. So we're going to bust these things out in under 10 minutes typically. So your patients should like that. Okay, so outpatient studies here. This one was looking at the analgesic effect of BFR. I'm going to let you look at the guts of that right there on your own. Basically, what they showed is that BFR can have a decrease in pain of up to 45 minutes, and that can allow a window where you can perform more joint loading activities with the patient than they could typically handle. So that can be important for recovery. This one was kind of cool. It talks about the tendon adaptations that happen in BFR. Basically, it kind of refutes an earlier study that said that tendons don't respond to BFR, and that people were really concerned about avulsions and tears for the tendon if you're getting increase in muscle mass but not corresponding increases in tendon stiffness and strength, then that could be an issue. So basically, the way that they conducted that earlier study, they were letting the restriction go between sets, which decreases the metabolite buildup, and from memory, I don't think they were increasing the reps during the period of time that they were doing this study. So both of those can factor heavily into a study. So this one looks at different percentages and energy expenditure. I'll let you look at that if you're interested in it. And then this one was kind of interesting. This wasn't a study, but they looked at the risk of venous thromboembolism risk. And basically what they came to is that if there's a pre-existing asymptomatic, VTEs are the greatest concern for not only BFR, but also any traditional training exercise as well. So thoroughly vetting your patients is going to be very important to make sure you have beneficial outcomes. Moving on to our elderly population, some of the improvements that BFR can offer them is increased muscle mass, strength, cardiovascular status. There's some studies showing bone density increase, increased functional outcomes with ADLs. So one of the things is going to be balance. If they have more muscle mass, they're going to be more efficient with their balance strategies. They're going to increase their microcirculation. That's going to happen to all of us as we age, and that's going to help support our muscle tissue and reduce sarcopenia. Sarcopenia starts at about age 30, and without intervention, you can lose 7 pounds of muscle per decade, so that's pretty significant, and BFR can be a great tool to counteract that. So we're looking at lower risk of injury and increased hypertrophy, so that's going to be a win for most of our geriatric populations. Some of the studies I found for geriatrics are, this one looked at the effects of low intensity walking. So we even see increases in strength and muscle gain with low level activities such as that. Okay, this is the one that I was talking about earlier. So they looked at 20 coma patients, and basically what they did is they put the BFR on one side or one extremity and not on the other side, and they did passive range of motion exercises with them, and they found that BFR was more effective than traditional treatment to prevent atrophy in coma patients. So this was actually a really cool study that I enjoyed looking at. So all that's laid out for you. These are some of the different units on the market today. There's more of them. These are just kind of a brief overview. The Delphi system is what I got to use at CSM, and it's pretty much a plug and play kind of thing. They strap it on you, and it's got a Doppler ultrasound in the actual cuff itself that monitors when your extremity is expanding or contracting and can maintain a constant pressure on that. It also has safety features in addition to that. So pretty steep buy-in at $5,000 is kind of like a BMW kind of analogy for BFR. If you're looking for more of a Honda type of buy-in, you can get a handheld Doppler unit for about $100. I've got a link to a YouTube video showing how to perform a Doppler ultrasound for BFR. The other thing that you'll need for that is the cuffs, and so you can find them for around $100 as well. Some other units on the market are the B Strong cuffs. Price range is about $400 to $800 for those guys. It's kind of middle of the road. And Katsu, that's another expensive unit, $5,000 to $6,000. I also found I was going to use these in class as well. This, you can get these on Amazon. This is just basically an elastic band with some marks on it, so you can keep track of where you're at. I got these for $30. This is kind of like the bike that you don't want your friends to see you riding, but it'll still get you where you want to go as far as BFR is concerned. Okay, these are the references that I used. And any questions? No? Okay, thanks for your time.